Karina, are you okay if we go ahead and get started?
Yep.
Great. All right.
That's good.
Great. All right, Karina, I will turn it over to you.
Yes. Well, hello, everybody. Thank you for joining us today for our Big Heart seminar series. Big Heart stands for Building Indigenuity and Generating HIV Science. It's a part of our HIV/AIDS research training program. And we're delighted to have our wonderful speaker, Dr. Missy Pacheco, with us today. And I'll introduce her in just a minute. But first, I wanted to acknowledge the lands in which we are situated at the University of Washington. We learn, teach, and live on the ancestral homelands of the Coast Salish peoples, whose ancestors have resided here since time immemorial. And our campus is situated on the traditional territory of the Duwamish people. And we also acknowledge that many Coast Salish peoples and other indigenous people who continue to thrive in these lands, all alive and strong. I also want to acknowledge the land that I'm sitting in from today. I'm in Snohomish lands and territories here in the northwestern corner of Seattle. Okay. And I'm going to turn over to Jen, who's going to talk a little bit more about Big Heart, and then I'll introduce our speaker.
Great. Thanks so much, Karina, and welcome, everyone. This is our third session in the series. And so I'm delighted that to actually co-lead this new program with Karina, and a little bit about this, and this might be familiar for those who joined us before. So the Big Heart program is a pilot program that's funded by our Centers for AIDS Research. And the goal is to really provide opportunities for meetings and mentorship for Indigenous scholars who might be interested in careers in HIV research across sort of the HIV research continuum. So one of the components of this is this series. So it highlights different Indigenous speakers working in different areas of HIV research. Another goal of the program is to connect folks with different networking events. And so you can stay tuned. There's actually an event we're going to plan for in the spring. As part of that, we'll be hopefully highlighting different opportunities for internship, job opportunities, different ways that folks can be engaged in HIV science. And then as part of that, we invite you all to register as fellows. So if you attend multiple sessions, you can consider yourself an HART fellow. And those that have attended multiple sessions can have the opportunity to attend the annual Principles of STI and HIV Research and Public Health Practice course. This is a course that is going to be held in a virtual format over several weeks. It's been going for 30 years and has been known all over the world. So it brings in different speakers talking about sort of the latest HIV and STI science. And related to that, we hope to have either in-person or sort of virtual hybrid mentorship sessions as part of the course. So it's a great opportunity for folks to engage further in their learning about HIV science and hopefully get to meet in person. We have the link, and I'll ask Anya to put it in the chat for more information about the sessions, and as well as your opportunity to register for our listserv and become a fellow. And so speaking of, before we get to our speaker for today, I want to highlight a couple of sessions that are upcoming for both May and June. We're delighted to have Dr. Michelle Johnson-Jennings, who is a new faculty member, professor in the School of Social Work here at the University of Washington, who will be speaking on May 10th. In a really phenomenal elders and practitioners panel that's going to be a do not miss. All of these are do not miss events, but in particular, I think this is an incredible opportunity to hear from elders and practitioners who have been working in the field of HIV for decades and hear their stories and hear their insights and lessons learned. So we're delighted to have the speakers that will be there, and hopefully you can join us for that as well. Now I will turn it back over to introduce Dr. Pacheco.
Oh, hold on. I have a dog going crazy and no one here to stop him. Hold on. Okay, we're going to have a barking dog. Just for a minute. I just wanted to first say halitosa hachifat Karina Walters Micha Oklahoma Tratasia. I'm enrolled in the Choctaw Nation of Oklahoma, and I co-direct the Indigenous Wellness Research Institute and am one of the principal investigators for the Indigenous HIV/AIDS Research Training Program that is partnering for the Center for AIDS Research for this Big Heart program. And having the privilege of working closely with Dr. Jen Balkas and our colleagues at CFAR I want to just extend my greetings to and aloha to Dr. Misty Pacheco. We are honored to have her here. She was born and raised in Hilo, Hawaii. She holds a bachelor's degree in chemistry from California State University, Sacramento, a master's degree in health admin from the University of Southern California, and a master's degree in health and a doctorate of public health degree from the University of Hawaii at Manoa. She has over 20 years of experience in the health field, working in both private and public sectors, nonprofits, and global public health. She's an associate professor at the University of Hawaii at Hilo in the Kinesiology and Exercise Sciences Department, in charge of the health prevention promotion track. Currently, she's I think you're a visiting professor at UC Davis? Yes. Her research is in line in the area of health disparities with a particular focus on Native Hawaiians and other Pacific Islanders. And her current studies investigate HIV as well as oral health care. She served as a public health Peace Corps volunteer in Kenya. She's a founding member of the Maikai Health Corporation, an innovative community health center in East Hawaii built with Public Health Foundation and focused on education and training. She's also the vice president of a nonprofit organization called Hui Kahu Malama that addresses the primary care physician shortage on the Big Island of Hawaii and promotes the rural health elective for medical residents. Dr. Pacheco also sits on the board of directors for the Hawaii Public Health Institute. That is a lot. And I'm so excited that she's here today to share some of her work. Just to shout out that she was a former Indigenous HIV/AIDS research training fellow, HART fellow, with us at Erie. And she completed a study of there called Disparities in Primary Care and HIV-related support service needs among Native Hawaiians and other Pacific Islanders living with HIV in Hawaii. And she's gone on to do some incredible work also in COVID as well. So without further ado, please welcome Dr. Misty Pacheco, one of our brilliant Kanaka Ma'ali Native Hawaiian investigators in all over.
Thank you.
So, thank you. Yokoke.
Thank you so much. Aloha kako. Thank you for having me. It's a privilege to be here and speak with you today. I'm going to share my screen right now. And here we go. Oh, hold on. Okay. So that was a long introduction. Thanks, Karina. I'm going to talk to you today. I'm going to give you an outline, and here's my outline, because what I'm going to do today is I'm just going to tell you a story. I'm going to tell you a story about my journey into becoming an educator and a researcher focusing on HIV and AIDS. So with every story, there's the who, what, when, where, why. So I'm going to start with who, a little bit about who I am, and then how I got into this work and why I got into this work, and then what that work is currently, and sprinkled in there a bunch of whens and wheres that make up this story. So bear with me. I know it's 4 o'clock. It's almost pauhana. It's almost the end of the day, but thank you all for taking the time to listen to me today. So this is the who. So I was born, and as my title said, a journey that started oceans away. This is the first ocean. This is the Pacific Ocean at the top picture. That's a picture of downtown Hilo. So I was born and raised in the town of Hilo on the Big Island of Hawaii. This is a picture of my family, and this is my ohana. This is the reason why I do what I did. I'm the oldest of 5 children. I was the first to go to college, and as the oldest sibling, I felt it was really a great responsibility to set an example. And so at the top, you see those are my 2 brothers. One lives in San Francisco, California, the other in Nebraska. And my sisters are at the bottom, and the top right-hand corner are my children with my mom. I have a 5-year-old and an 8-year-old. My dad's in the middle with all of us, and then my stepdad is there on the left. If you guys know anything, I don't know if there's some people here from Hawaii, but we're all mixed. It's a very diverse state, very diverse population, and I have family. My family is made up of people, indigenous of Hawaii, specifically from the island of Maui. Family, my ancestors come from the Southeast Asia, specifically the Philippines, also Asia, larger Asia in Japan, and then towards the European continent in England and in Portugal. So we're very diverse. And as you can see from all of us, we kind of, we all look kind of different, but yeah, this is me. And in describing who I am, that's my family is super important. So the how did I get into this career and into research? I started my journey at Oregon State University, my educational journey. So still staying within the Pacific Ocean. I didn't want to go too far, but I knew that I wanted to experience life outside of Hawaii. I'd never been to the mainland, and I knew that that's where I wanted to go to school. And that was an opportunity for me to do so, to get away and kind of learn about other cultures. And so I started at Oregon State University simply because that was like the only university my parents could afford. It's a WUI school, Western Undergraduate Education. So it's a WUI school. You don't pay out of state, but you don't pay in state, something in the middle. So unless I wanted to stay home in Hawaii, my mom was like, that's about all we can do. So I ended up going to Oregon State. It was a great experience. I was an environmental science major because as a WUI student, you can only choose from specific majors. And I knew I wanted to major in science because at the time, what I thought I wanted to do was become a forensic pathologist. I watched a ton of forensic files. I still watch it to this day. Actually, that's what I did right before I joined this, to kind of like just calm the nerves. I was like, I'm going to watch some forensic files. So that's what I wanted to do. And after being an environmental science major and taking some GEs, loving chemistry, I was like, I think I should transfer and I'll make it work. So I did some research online, like, where can I go if I want to go into forensic science? Nearby on the West Coast, I found California State University at Sacramento, who had a forensic chemistry program. So I transferred to Cal State. I ended up getting my degree in forensic chemistry and working right after. I knew I had to get, to be a forensic pathologist, I had to go to med school. So I started getting volunteer observation hours at UC Davis Health Center and realized that I did not want to do that. I didn't want to go into medicine. It just wasn't for me. However, I loved healthcare. I loved the fact that we saw people come in and I would talk to them and, they'd be sick or they'd be hurt and then they get better. And I really liked healthcare. I liked the energy of a healthcare facility. So I decided to apply for a master's in health admin program, chose USC and moved down south to Southern California. And the woman you see there in the corner, she's an important part of my story. She was the director of the USC MHA program at the time, and she wanted diversity in our quiz bowl team. So there was a quiz bowl team in USC, the Southern California Health Executives Quiz Bowl, and I was the only brown person, the only female on that quiz bowl team, and we hadn't won, I don't know in how many years, it was a lot of years, but we ended up winning second overall that year. So Dr. Lavana Lewis was like, oh my gosh, what are you gonna do after? I owe you, how can I help you? And I was like, I don't know what I want to do, but I think I want to stay in healthcare. And she suggested, she had contacts all over the country. And she's like, well, I have contacts at the Clinton Foundation. Is that something you want to do? They're building dispensaries and clinics throughout sub-Saharan Africa. And I was like, wow, I've never been out of the country. I barely made it out of Hawaii, but sure. So I had my mindset that I was now going to go global. And long story short, that fell through because of conflict in the country that they were building. I think it was Ethiopia. And at that point, I had my heart set on going global. And she suggested to me, have you ever thought about the Peace Corps? And I was like, no, I never. I don't know anyone that served in the Peace Corps. And she's like, well, why don't you do some research about it? I think that would be good for you. I think you would enjoy that. And she said that in a joking way, because she said I was very idealistic. She said, and some of my professors had told me that too, like that I could actually make a difference, and that was being, very idealistic. She's like, I think you should look at the Peace Corps. I went home that night, checked out the website, did the application, and probably almost a year to that day, I got my assignment and I left, and I ended up in Kenya. So I was a public health Peace Corps volunteer in Kenya, and this is the continent of Africa, and in this red, this is Kenya. It's a country with the east part of the continent in the Horn of Africa, and here is Kenya. And my assignment was in a little rural village called Wote in Makueni County. So probably right in the middle between Nairobi, which is the capital city of Kenya, and Mombasa, which is the eastern port. It actually serves all of Eastern Africa. It's a major port of entry. So this is the where and the why. So this is another where, important where in my story, Kenya as a public health Peace Corps volunteer. And this is truly the why I chose to get into research and public health and focus on HIV/AIDS. It all starts here. The projects that I did there, you can see in the left-hand side, I'm talking about sexual reproductive health. And this is 2 orphans in the Mombasa area in an orphanage. And they're orphans, majority of the orphans there are there because their parents had died of HIV/AIDS. And the other project I did was an HIV prevention program for women. At the time that I was in Kenya, they were growing rapidly. They were building a ton of new roads through these remote villages that had never seen an outsider. And what comes with that? What comes with that is a lot of traffic and disease. So we were focusing specifically on commercial sex workers, because what was happening is these roads were being built. Truck drivers were coming in from all parts of Eastern Africa, Uganda, Sudan, Ethiopia, Tanzania, to go to the port, right? These truck drivers. And so they were for money. There wasn't much to do, and they were turning to commercial sex work, and they would get paid more if they didn't force the man to use a condom. So what we did is we gave them education, of course, but we also armed them with female condoms, taught them how to use them, gave it to them for free, and that was our project. It was here that I know that my passion for, I didn't even know at the time I was doing public health work, but that's where my passion for public health was ignited. And it was there, back home in Hawaii, and even in the United States, when living in California, of course, I'm a child of the 80s. I was born in late 70s, grew up in the 80s. And that's when, the HIV epidemic first started. And we would learn about it in school, but it's all these fear tactics. And there weren't many people living with HIV and AIDS in Hawaii. And so I really didn't come into contact with any. It's here. The disease was real to me. I mean, every other day I met someone that, was infected with HIV, and it became a real thing to me. And I knew that there's so many things still to be done. I mean, in this rural town, there's only so many resources they had. And I knew that when I left, I would have to continue this work somehow. I would end up leaving early because during my time there, the presidential election was going on and the country erupted in civil war. So I was abruptly evacuated out of the country, sent back home. I got a call 4 months later and was asked if I wanted to do some relief work. My mom didn't talk. I agreed, and my mom didn't talk to me for a while because she was so upset that I was going back. But I had to go back because I wanted to leave on my own terms. And there were so many people I didn't get to say goodbye to. And I didn't like leaving work that just felt there was no closure. And I wanted to kind of tie things up. And so I ended up going back. And when I left, it was, I told everybody that I need to tell bye. We finished our project, and I felt good about that. And so leaving the Indian Ocean right? So this is, by the way, another ocean, oceans away right here. This is the Indian Ocean. After leaving there, I go back to the Pacific and I ended up back home in Hawaii. So upon returning, like I said, I knew I wanted to do public health. This is another where and when. I knew I wanted to do public health, and I knew I wanted to somehow still work with HIV and AIDS. And so I first got a job at the Hawaii State Department of Health as a public health educator. I worked alongside different clinics throughout the state and focused on STDs and HIV as well. I represented the Department of Health on the CPG. The CPG is the community planning group. And so as a CPG member, it's required actually by the CDC for federal funding. We planned and prioritized HIV care and prevention strategies. So I sat on the CPG and got to learn about what were the priorities and what were the barriers, the challenges when it came to HIV in our home state. So I knew that if I wanted to continue this work and if I truly wanted to do public health, I would probably have to go back to school. And so I chose to go back to school, and I ended up going at Manoa, University of Hawaii at Manoa, and I got my doctorate in public health. After I graduated, I quit my job at the State Department of Health and I moved back home to the Big Island where I'm from. And this picture right here at the right-hand corner, this is me. In the middle of that, I had a child. So this is my 8-year-old daughter. And this is a board member. I became the executive director for the AIDS service organization on the Big Island called Hawaii Island HIV/AIDS Foundation, or HIHAF. And as an executive director, I got to specifically learn more about now what are the issues and the challenges and the priorities for HIV on the island. And I got to know at that time our people living with HIV/AIDS on the island very personally. It was a great experience to meet everyone and to really, really address some of those issues in my backyard where I grew up. The issue though was that I hated being an executive director. I just was like, I don't want to manage people. I'm not there. I was used to, being a volunteer in Kenya, being on the front lines, on the ground, grassroots, working. And I didn't have that opportunity to do that at HIHAF as the executive director. So I kind of tried to reevaluate what I wanted to do with my life. And many of you might know Dr. Kaholokula from Manoa, and he's one of my HART mentors, but he introduced me to faculty at the University of Hawaii at Hilo, and they happened to have a faculty position open. And I thought, this is a way I can put my skills to use. I can actually do research and get back into the community on the ground. And I got the job. And it was during that time, shortly after, like Karina mentioned earlier, I became an HART fellow. And so this, for those of you at UW, this is familiar, right? This picture, this is a summer training program at UW campus, beautiful campus. And those are some of the members of my HART cohort and some from another cohort. But this is the opportunity I had now to really design my first HIV focused study, research study for my community. And so if you're not familiar with Hawaii, just briefly before I go into the what of my story, what my research is, our population, this is the latest data from the census. Our population throughout the state is a little over 1.4 million. Hawaii County, the Big Island right here, where I'm from, a little over 200,000. And so when we talk about the race data breakup, what I told you in the beginning, like everybody growing up in Hawaii, I don't think as a kid we even knew like race was important. We all kind of just looked like each other and thought we were all local, we we're all Hawaiian, but we're very diverse. Hilo, actually, my campus was voted the most diverse, 4-year institution in the country a couple of years in a row. But this is the breakdown, the latest from the 2020 census. And as you can see, the red is white alone. So this is people that identify as white alone, 25%. Those that identify with 2 or more races, 24.2%. Asian alone is the largest in yellow, 37.6%. You have Hispanic or Latino in green, 10.7%, and that's alone. Native Hawaiian or Pacific Islander alone, it's a smaller number, 10.1%. And then in the far right-hand corner, those that identify as Black or African American alone, 2.2%, and American Indian and Alaska Native alone, 0.4%. So there's not many people that are just one thing. So alone or in part, Native Hawaiian Pacific Islander for the state, that number is going to be a little larger. It's about 27%. And then Hawaii County, 35%. So now when it comes to Native Hawaiians and Pacific Islanders and HIV/AIDS, the CDC reports that Native Hawaiians and Pacific Islanders are third highest diagnosis rates behind Black or African Americans and Hispanics or Latinos. Now, when we look at the data or the picture of HIV in the state of Hawaii, it's a complicated picture. That's one of my research. We put that in our paper. She was like, oh, I don't know what to make of this. It's very complicated. And the reason for that is if you look at overall at this time, so this is 2019 data right here. That's the latest data that I have at this time. But at that time, the population identified as Native Hawaiian or Pacific Islander was about 20%, and 11% of HIV cases were Native Hawaiian or Pacific Islander. Of those living with HIV or AIDS in the state of Hawaii, viral suppression, we track that, right? The continuum of care. And Native Hawaiians and Pacific Islanders are actually doing better than the average when it comes to viral suppression. That means they're engaged in care, 75.5%. So when we're kind of designing my HART study, we're kind of like trying to understand which direction we should go. We're kind of really looking at the data. And so that happens with a complicated picture. People, they don't make up the largest portion of people infected with HIV/AIDS in our state, and they're doing better than the average when it comes to viral suppression. However, Dr. Sintel, who is from Manoa, she did a study in 2014, and she found that actually Native Hawaiians and Pacific Islanders are more likely, those with HIV are more likely to be hospitalized, and they're more likely to have late diagnoses. So we decided, okay, why don't we do a mixed method study? Let's do a deeper dive into the data that's available, and then let's get people's stories, right? Let's talk to them. And so that would be the qualitative piece. I think fortunate for us at the time, and I worked at the Department of Health, so I know it's a requirement of funding, of federal funding. The states have to do a Ryan White needs assessment, and one hadn't been done in our state for a long time. And so finally, Department of Health, with partnership with the AIDS service organizations throughout the state, we're like, okay, we're gonna do one. And I was like, perfect. That's what we're going to assess. We're going to assess and analyze, do a secondary data analysis of the statewide needs assessment. So this is my research, my HIV research. I'm going to start with sharing you a little bit about my HART study and what we did, and then another study I'm doing as well. So my HART study, health outcomes and healthcare utilization of Native Hawaiians and other Pacific Islanders living with HIV in Hawaii. It was a mixed method study. So we had a quantitative phase 1, a qualitative phase 2. And this study was just published in Ethnicity and Health at the end of last year. The purpose was really to examine the differences in viral suppression and satisfaction with care between Native Hawaiians and Pacific Islanders, and then all other ethnic groups. And we did this, the quantitative part, by, like I said, analyzing the Ryan White needs assessment that had not been done in a really long time, and identify factors relating to care, satisfaction with care, viral suppression, from the lived experience of people living with HIV in Hawaii, Native Hawaiians, Pacific Islanders living with HIV in our state through interviews. So there were about 400 Ryan White clients that completed the needs assessment, and we interviewed about 16 Native Hawaiian or Pacific Islanders living with HIV throughout the state. And what we learned was, well, I'm going to back up a little bit. So this study, the quantitative and the qualitative, was guided by a specific model called the behavioral model for vulnerable populations. So you may not have heard of this model, but you probably have heard of Anderson's behavioral model of health services. That model is specifically utilized to predict or explain one's use of healthcare services. And the BMVP that we used was really utilized it's an ideal model because it's used to assess health services amongst vulnerable populations. So these factors in the model are divided into traditional factors. That's the original Anderson model. And then the shaded factors you see there are the vulnerable factors. These are factors that can be tailored specifically to vulnerable populations. And we felt that this was an ideal model for this study because the factors that make Native Hawaiians or other Pacific Islanders living with HIV/AIDS in Hawaii vulnerable, such as stigma or sexual orientation, could directly affect their utilization of care, right? And so that's the satisfaction of care outcome, as well as health outcomes, which we chose to be viral suppression. These factors are divided into 3 categories, and you can see those 3 categories here at the bottom. Predisposing factors, these are more the intrapersonal factors of a person that includes culture. And enabling factors, these are the support services, the resources people have. And then need factors, basically someone's overall health or the severity, taking into account the severity of their disease. So we utilize this framework to guide not only what we were gonna assess, those questions of the needs assessment that we're gonna assess, we separated them by each of these categories of factors, but we also used that framework to come up with questions, so that questions directly asked about those specific categories of factors. What we learned was that, again, it aligns with like the complicated picture that we thought was going on in Hawaii. There was really no differences. When we looked at the secondary data analysis, we're like, okay, there's no differences, but there was one we could find. Native Hawaiians or Pacific Islanders are more likely to have a higher viral load. But remember that study I told you about in the beginning about that Dr. Centel did, that they came in, higher hospitalization rates, coming in more later diagnoses. So this finding actually aligns with that. They have a higher viral load of over 10,000 copies. Other than that, there were no other differences. So we're like, okay, well, let's do the qualitative piece and see what we find. Let's try to understand this, right? Let's try to get people's lived experiences. So when participants were interviewed, again, 16 throughout the state, we found 4 significant themes. So the first theme was not a surprise to me. And for those of you that work in HIV, I'm sure you understand the hugely important role that AIDS service organizations, ASOs, have. And so care coordination we found was essential, and ASOs should take the lead. So they were the most important enabling factor for our interviewees. The ASOs got them the help they needed for not only care, but for other social services. So that wasn't surprising to me. And, working in ASO, it was happy to hear that we were doing a good job. The second theme, HIV care as well as overall health, is defined by the effectiveness of medication. No matter what question we asked, I would ask them, I interviewed them. So I would ask them describe to me your overall health. Or I would ask them how's your relationship with your doctor? It would always come back to medication. They would be like, well, I'm on good meds. So yeah, my health is good. Or they'd say something like, my doctor's good. He makes sure I'm on my meds and I take my meds. And so that became an important thing for us thinking about future interventions, that medication is important. And that makes sense. Our outcome we're looking at is viral suppression. To achieve viral suppression, they got to get on those meds and take them how they're supposed to be taken to be undetectable. So that theme, okay, important, but not surprising. The third one wasn't surprising either. Everybody in talking about their experiences, when talking about the need factors, the severity of their disease, they would always think back to their initial diagnosis, right? That's the scariest time. That's probably the time they were the sickest. And they were just talking about how upon diagnosis, ASOs were right there, helping them, right there to be like, we're here for you. We're going to get you into care. It's not over. Other people had family support as well. So we learned, because this initial diagnosis, time came up again and again. So we're like, okay, this is a time, future interventions, we have to make sure, for new diagnoses. This is a point, a critical moment for interventions. This is where we got to get in, and viral suppression relies upon that to get in at that moment. It could be the make or break of whether someone actually engages in care. This fourth theme, though, this is the one I think that was the most intriguing theme for us. Aspects of culture are intangible. I knew what I wanted this theme to I knew I wanted to talk about with this theme, but I was having a hard time coming up with a title. And so I was actually talking with Dr. Kaholakula multiple times over Zoom, and I was like, what's a good title for this? So we just talk out the theme, and this is what we came up with. And the reason why that's the title of this theme, and why this theme is so important going forward when it comes to HIV/AIDS interventions for Native Hawaiians and Pacific Islanders living in Hawaii and even abroad, is because when participants were asked directly, what is your experience regarding their HIV-related care as a Native Hawaiian or as a Pacific Islander, many were initially confused. Like they'd be like, what? Misty, repeat what? Repeat that again? Wait, say it in a different way. What do you mean by that? They were really confused. And so I'd have to repeat the question. Some simply stated, it's not related. My care and me being Hawaiian, it's not related. I would follow up because I kind of want to dig deeper into that. And I would follow up with like, okay, do you feel your care is sensitive to your cultural values or your perspectives? And some participants weren't able to actually explicitly connect culture with their care. However, when some interviewees talked about various factors, so that the culture, right, that's that predisposing factor. When they would talk about other factors like enabling factors, they would talk about how important Ohana is, how important their family is supporting them throughout this whole process, even when they were first diagnosed. And that's a Native Hawaiian value, right? And it's also Pacific Islander value for other Pacific Island cultures. And so, and other examples, like when they would talk about enabling factors, like their physicians, they would talk about like physicians that they really respected and they really loved. And it happened to be all these physicians or staff from ASOs that they described as local. So either born and raised in Hawaii or Hawaiian, or having a local or Hawaiian or Polynesian name, they felt most comfortable. So even though when I would ask them explicitly, like, is there a connection, you being Hawaiian, you being Samoan, you being Micronesian, is there anything does that affect your care? Does that affect, does that affect your relationships with others? They're like, no, it doesn't. But it was clear that in talking about those other factors and when asking other questions, that it actually was. So that theme was like a light bulb moment for us. And, we concluded, and like I said, that paper has been published, that even though there's this complex picture in the state of Hawaii when it comes to HIV/AIDS, any interventions going forward, we need to address all domains, all factors of the BMVP, because all those factors gave us really important information. And attention needs to be put to culture, and people may or may not realize how important that is. But our study revealed that it's very important. I did these interviews during the time of COVID. So these interviews were supposed to be in person, but it was COVID and I could only do it. I couldn't do any in person. Our IRB at the time was like, no in-person research. So I did these interviews by either Zoom or by phone. And so I went back to IRB and I was like, I'm not going to add new questions. I just want to find out, I'm going to ask the same questions, but I want to ask them, like, has this changed because of COVID? Because, well, knock on wood, I hope we don't have another pandemic coming up soon, but I wanted to really capture the moment, what's going on in a pandemic, something we haven't seen in our lifetime, right? So they allow me to do that. So I won't go into the study too much because it's utilizing the same methodology. I presented this at a conference, at a health behavior conference in Florida a few weeks ago. But the themes that were revealed, it was interviews. And the themes that were revealed were very similar. Again, number one, ASOs play a major role during times of crisis. Again, their important role was identified even in focusing on the COVID-related questions. So going forward, God forbid if this ever happens again or any emergency, we suggest that, resources, you have to include the ASOs in getting resources out or education, any kind of help out to people living with HIV in our state. The second theme, if you remember from the first study, I kind of told you how every time we asked the question, it would always come back to the meds, right? This time, a little bit different. We'd ask questions and it would always come back to mental health. And that's not too surprising. I mean, that's all of us. I mean, in the middle of the pandemic, I was super stressed. I was homeschooling 2 kids. I could not, I was gonna go crazy. And so that wasn't a surprise either, that mental health took priority. But yeah, the meds, they didn't even mention that. It was all about, I'm stressed out, I'm fearful, I have so much anxiety, I don't want to get sick, I'm immunocompromised, which plays into the third theme that we found. The tables are turned when it comes to disease infection. It was really interesting. This is something I noticed in Kenya when I was doing that, stigma, HIV stigma is still a huge, huge issue, right? Like stigma, I learned early on in Kenya that stigma prevents people from getting the care that they need. It prevents people from disclosing their disease status. People don't want to be, it affects education, right? And so I experienced that there, and I even experienced it when I worked for the ASO. And I'm going to share something with you that has stuck with me, and it still makes me emotional to this day. While I was the executive director at HIHAF, I was pregnant. And so, our clients come in on a weekly basis, and I see them, they come in to go to the food pantry and they would see me pregnant. And then, I gave birth while I was there. I was off for maternity leave and I came back and I would bring my infant daughter with me to work. And the clients would come in and they'd be like, oh my gosh, you're back. You have the baby. And they were so excited because we're just a big family. And I remember one of our clients, he came in and he was so excited. He wanted to see the baby. And he's like, let me see her. Let me see her. And I was like, here. And I went to hand her to him. And he freaked out and he went back like this. And he was like, no, he was like, no, are you sure? He was scared. And I was like, oh, I'm sorry. I thought I had done something wrong. I was like, I'm sorry. Do you want to hold her? I just thought you'd want to hold her. And he's tearing. He's like, you are going to let me hold her? And I was like, yeah, of course. Why not? And he's like, I've never held a baby. No one wants me to touch their baby. And that broke my heart. So that stigma, right, is so important. It's so detrimental. It's something we still deal with today. And in these interviews, the tables were kind of turned because I would hear that from our clients all the time, how people are still uneducated about HIV. They still think that, they can't come near me. And now the tables were turned. These people are like, I don't want to leave my house. I don't want to get sick. I'm immunocompromised. I don't know who has COVID. I don't want anybody touching me. And it was just such an interesting theme. It came up over and over again. feeding into that mental health, right? Just that anxiety that they didn't want to be around others. They didn't want to be touched. They didn't want to be breathed on. And so we thought like, wow, that's so interesting. And the fourth theme for this study, telehealth is crucial and should be here to stay. I'm actually, like we mentioned in the beginning, I'm a visiting professor at UC Davis right now, and I'm here working on a big project focusing on COVID. And we're focusing on a lot of the Central Valley migrant farm workers, and it's a telehealth. It's actually a telehealth project. We're focusing on telehealth. And so we found this in our study. That wasn't surprising that telehealth is crucial. You know, people were able to still carry on with their appointments, their medical appointments, see their doctors, see their therapists. And that was really important for them to not disrupt that care. And telehealth allowed them to still have that, whether it was video conferencing like this or whether it was on the phone. So that was huge. Many insurances don't allow for that. If you don't have the right insurance, if you're at a clinic that doesn't have the resources, majority of Hawaii is very rural. So telehealth being equitable is going to be an issue. It is an issue. And so going forward, I think that's something we concluded, something that we have to focus on. It is here to stay. It should be, and we have to make sure that it is equitably available. So how you guys doing? 40 minutes, almost there. Bear with me. This is my last study that I'm going to talk about very briefly. And the title of this HIV study is a pragmatic trial of an adaptive e-health HIV prevention program for diverse adolescent MSM. And I partnered with Northwestern University on this study, the Feinberg School of Medicine Institute for Sexual and Gender Minority Health and Wellbeing. They were implementing an HIV prevention e-health program called SMART for adolescent MSM. The purpose of our study was to understand Native Hawaiian or Pacific and other Pacific Islanders or MSM, because they were having a lot of issues. They're having challenges getting and recruiting Native Hawaiian, Pacific Islander, adolescent MSM into SMART. So we all kind of talked and we're like, well, why don't we do some focus groups and try to address, find out what should we be doing? How should we recruit and approach adolescent MSM for an e-health HIV prevention program? For those of you that have dealt with IRB, you know how hard it is, right? If you don't have to deal with minors in IRB and get parent approval, especially for a topic like this, we didn't want to go there. So we were like, okay, how about we do near peers? We talked to near peers because they were young, not too long ago in that age group, and they can still inform this, they can inform this study. They can speak to where teens hang out, what gets their attention, and so that's what we did. And this turned into interviews because, again, we're still dealing with COVID. It was going to be really hard to get a focus group put together. So just briefly, the themes that we identified, number one, culture is a crucial factor for recruitment and engagement, whether participants realize it or not. Does that sound familiar? That's what we found in our first study, right? This idea of culture. It's just I don't know, maybe it's for others too. I haven't really looked into it, but for our participants anyway, and even in my previous studies, intangible. It's coming back to this theme, right? So overall, almost all of the interviewees in this study, and we interviewed about 20 Native Hawaiian Pacific Islander MSM ages 19 to 24 throughout the country, actually, and territories of the United States Pacific Island territories. And almost all interviewees, when asked, like, what gets your attention when it comes to online spaces, including ads or videos, some described specifically Native Hawaiian or Pacific Islander cultural elements. Some said specifically, like, I want to see my culture in there. I want to see me. Other participants directly stated that what would get their attention would be like, art, but not connected to culture. So it was interesting because those that tied it to culture and said they wanted to see their culture, they would say, like, I want to see I want to hear Hawaiian music, maybe. I want to see dancing, hula dancing. That would get my attention. And others that didn't like explicitly say, like, I want to see my culture, they would still talk about the same cultural elements like art, music. So that is an important theme. And again, we saw that similar in my other study, right? The second theme, not surprising, confidentiality is key in recruitment to provide a safe space for teen NHOPI MSM research participation. This is a time where many have not come out yet to their parents. Many, like the islands, not just the state of Hawaii and all of our islands, the Pacific Islands, and those that we interviewed that were on the mainland, it's very rural. A lot of it is very rural and everybody knows each other. So that confidentiality, that anonymity is key. And they said that needs to be made known because we don't have any safe spaces growing up. We didn't have many. We went online to kind of meet others. So, we suggest going online, recruiting that way, but making sure upfront, over and over, say that, it's confidential and anonymous. The third theme, Native Hawaiian and other Pacific Islander MSM experience multiple identity conflicts that must be considered for recruitment and engagement initiatives. I think this theme for us was the most, for this one, this is the one that we kind of dove deeper in, and it's going to be part of our next steps. So this single theme, I think, began to not just shed some light on understanding the difficulty of reaching Native Hawaiian and Pacific Islander teen MSM, but reaching Native Hawaiian and Pacific Islanders in general when it comes to research. And I'll tell you why. It speaks to different complexities. So as the theme says, we kind of broke down that identity conflicts into 3 sub areas. There seem to be many forms of conflicting narratives that interviewees were struggling with that prevented them, especially in their formative years, their vulnerable years of participating in research. They didn't really feel like they had a true sense of self because of these identity conflicts, and therefore was like, what would I have? Like, how would I contribute to research? I don't feel like I can speak to research and give you good feedback. And so this identity conflict, we broke it up into 3 parts. The first was religion. Many, not just Hawaii, but many Pacific Island countries, they were colonized. They had an influx of missionaries, and many Pacific Islanders, many Hawaiians, really clung on to this new religion, mainly Christianity. And of course, Christianity tells them that, homosexuality is not acceptable. And so that religion was really hard for them. They loved their family. That's a Native Hawaiian, and many, it's a value with it throughout the Pacific Island. They loved their family and they knew their family loved them, but they were also very religious. So that inner conflict was really hard for them when it came to religion. Another one that was really hard for them was just the cultural acceptability of being gay. Native Hawaiian culture, when you look back to the historical writings, there is some writings in history that would suggest that homosexuality was totally accepted. The king had a very important confidant that they talk about in these historical writings. One of the authors, it's not my area of expertise, but he has a PhD in Hawaiian language and revitalization. And he went back to all these historical documents and was like, culturally, we can see how perhaps it is acceptable, right? And for other Pacific Islander territories and countries, it was also acceptable, like in Samoa and in Aotearoa in New Zealand. And so that led more to this identity conflict, like, oh, here religion says it's bad, but here in our culture, it's accepted and it's revered. And so really trying to understand that was difficult for many because they're taught in school one thing and then taught something else outside of school or even within school, depending on what school you went to. And then the third one was just this mixed, they talked about just having this mixed, this differentiation, like you're wanting us to come into research, but I'm Samoan. And even though my culture is very similar to Native Hawaiians, it's still different. And so the strategies that you might, utilize to recruit Native Hawaiians, I might not identify with that. And you're always lumping us together. And we know that that's an issue. I mean, as researchers, we knew that was an issue. There's many publications in the literature that talk about that being a real issue. And so this just adds to the literature base, right? That it is, even for our young Native Hawaiian Pacific Islander MSM, this becomes something that they struggle with. Like, why should I participate when it's truly not to me? You can't lump us all together. So all of these conflicts, it was so much to sift through, as you can tell. I'm like thinking back to it and it's like all coming back to me, how we'd all talk about it. But what we concluded was that no matter what, recruitment efforts, okay, we learned we have to stress confidentiality. We learned that maybe we should go online because that's where they said they went to meet others and that's where they learn. And we also need to make sure that, culture is in there, because whether they realize it or not, having those cultural elements weaved into any recruitment materials is important and it's going to get our attention. But also that education piece, that cultural education piece, I think we need to really think about, do we want to really separate? We should separate our efforts when it comes to just, Native Hawaiians, other Pacific Islander countries and territories, different cultures. We should probably separate that. And then we do have to dig deeper into the cultural acceptance that our young men seem to struggle with, and also the religion aspect that they seem to struggle with as well. So to address that, that's our next step. So Northwestern, we're still talking how we can all, same authors, how we're going to kind of look to maybe applying for an R15. So R15 allows us to have student researcher participation, right? And these interviewees that I interviewed for this study, some of them were in college and so had some background knowledge on like methodology and stuff, but they were so awesome. I was like, I want to get those guys into research. I want to get them designing and implementing these studies because they were so on it. They were so akamai. They knew like, yes, this is what you need to do. This is what we need. And I was just blown away. So I would love to get Native Hawaiian Pacific Islander MSM involved in research. And so we thought we're going to look into this and really try and do that. And maybe the study be broken up into like focusing on Hawaii, but maybe 2 other Pacific Islander countries and territories to really dig deeper into that conflict and those real differences when it comes to culture, and really sift through that because that was a really deep theme and we knew that that's really important. We got to get down into that. Our participants told us so. So I'm right at 50 minutes and I know I've been talking a long time, but I just want to say mahalo. Thank you for taking the time out of your schedules to listen to me, and I will answer any questions that you may have. But yeah, thanks.
Mahalo, Misty, for that incredible presentation. I just loved your being able to share your journey, what inspired you, where you began, how culture framed that for you, but having these cross-cultural experiences then help to drive home the importance of looking at this back at home and bringing it home and all of that. So I really appreciate that. And you've raised a ton of questions for me. Certainly the issue, we in American Indian, Alaska Native communities, we talk about culture as medicine. But our elders also teach us, you have to meet the medicine halfway. And so to me, when you were speaking, it really made me think about the complexity of identity, intersectional aspects of identity, being LGBT, Two-Spirit, queer, trans, Native people, And then the deep cultural roots of what that means, more within cultural nuanced understandings of that as a third gender expression and other kinds of ways in the islands as well. It's very complex. And I think your research really points to the importance of deepening and looking more closely within Native Hawaiian communities, particularly our Native men who are disproportionately affected by exposure to HIV and how do people understand their experience. So we're going to open it up for questions. We're going to encourage people, if you're a little shy, that's okay. You can always put it in the chat and we can raise the questions. Otherwise, you're going to have to just put up with me and Jen asking questions, but I think it'll be better coming from everybody else. And Cherry, thank you for sharing the comment about Moi Aikani. I don't know if I'm pronouncing that correctly.
Yeah, that is the like when I was talking about that male confidant, the king had that taught that I talked about earlier for the second study. That's what the author, one of our co-authors, Keahi Warfield, he wrote about that in the discussion section. It was really interesting.
So